Hello, good evening, good day, good afternoon, good morning, wherever you are in the world. And welcome to the Black Belt Academy of Surgical Skills. If my microphone is a little quieter this evening, I've hung it on the lampshade further away from me such that I can demonstrate posture. I would like to thank the 1,170 people who like Black Belt Academy of Surgical Skills. I'd also like to thank the 2,825 followers. It is much appreciated. Please spread the word. This evening, I debated whether to call it Make a Stand or Stand Up, because success is defined not by how many times you fall down, but how many times you stand up. And H.G. Wells said, if you fell down yesterday, stand up today. Another important thing is that you stand up for what you believe in, even if it means you stand alone. But I'd also say as a surgeon that you stand up for the patient, because that is what we have the privilege of doing, and they depend on us. But in order to do our job properly, we need to go back to the very foundations of what we do, and most of us operating are standing up. Now it's recommended you should stand up 2 hours a day, to a maximum of 5 hours a day, and after 8 hours it is documented with the pooling of blood in the lower limbs and the edema, with or without long saphenous vein incompetence, increases the oxidative stress of the body and puts you at risk of heart disease. Not only that, there's an increased incidence of musculoskeletal problems. Now, there's a study that I've put on the website under posture for you to read that showed that 97% of plastic surgeons actually suffered some degree of discomfort in their back or their neck after surgery, lasting up 3 hours to 3 days following the operation. And a colleague of mine in Manchester did a study of the incidence of neck problems amongst cardiac surgeons and found that 75% of cardiac surgeons had some cervical spine problem. I myself have had fusion of C5, C6 through wear and tear over the years. I can say that I've got radiological evidence that my head is screwed on, but some might argue whether it is screwed on correctly or not. There's a certain sect of Indian Buddhas, the Sabhas, or standing Babas, or Karishami, or Shwari, that inflicted corporeal punishment on themselves in the form of Hindu vows or tapas. And the standing Babas are reportedly have said to stand up to 12 years, neither lying down to sleep nor sitting, but suspending themselves in a sling at night to rest, but spent their lives standing. And this resulted in severe musculoskeletal problems, joint deformities, and even fixation. One of these postures translated into yoga, called Vrikrashama, which is the tree position, standing, hands above your head, standing on one leg and holding that position. Now apparently over 40 it's rare that people can stand for 10 seconds in that position. And an MRC study demonstrated that the ability to stand on one leg correlated very well with frailty and the risk of falling. Certainly in karate, Surya-Shigashi in Pinanyodam, Peaceful Level, Mind Level 5, required you to stand on one leg for 2 minutes with the right leg raised at 90 degrees such that you could put a teacup on it. And the sensei used to come round and push you over to see if you could still stand in that position. The point is that posture is fundamental to all sports. And before you start any sport, you need to get in the right posture. In the Power Excellence courses, I describe a metaphor on golfing. Grip, address, stance, position. We actually go to a golf course in the evening to go through the principles of alignment, holding the instrument, and more importantly, how you stand. Because 80% of golf is getting in the right position, which is an odd position of your bottom sticking out, your back straight, your arms hanging down as a pendulum, or the club aligned at 90 degrees and swinging through and transferring the weight from your back foot to front foot as you come through with a swing. The same is applied in martial arts. And a lot of the work with the sword, again, is described in the basic position held in a Zenkusu Dashi, with the sword held up with the kasaki pointed at the throat of your opponent, such that if they ran towards you, they'll impale themselves on the end of the sword. What is interesting, that a lot of this is described in our sports, but not much of it has been highlighted in our profession. And I recall when I was training at the Brompton Hospital, Mr. Lincoln, during an operation, asked the sister for a crepe bandage, and I wondered what he was up to. And he took that moment to take the sterile crepe bandage and he bandaged me to a drip stand. He said, "There, now I'm going to correct your posture and your position." And after 15 years of training, nobody had highlighted that issue. I subsequently repeated that when Jake Timothy, who's now a consultant neurosurgeon, when he was a registrar on the firm, and he's never forgotten it either. And the reason for that is important, is how to stand properly. And I'll try and demonstrate that to you using this elastic and the positions. So fundamentally, as we're standing, from the crown of the head to the tip of the ear, through the shoulder, through the elbow, the hip, the knee, and to the ankle, should be a straight line. Now we have common problems in surgery. The first of all is inclining the head, but pushing it forward. Now the interesting thing with that is, for every inch your chin goes forward from the midline, you are adding 10 pounds weight to your head. So that is 4 kilos for every 2.5 centimeters. So at 5 centimeters out, your head is going to be weighing an extra 20 kilos weight. Now consider that weight on your neck and your shoulders. The second thing is, as we lean forward like that, there's a tendency to rotate the shoulders in. And in rotating the shoulders in, you're actually putting further strain on the back, the thoracic spine, the cervical spine, but also shortening the pectoralis muscles. The other common problem is we start elevating the elbows. And as we start elevating the elbows, you fix the scapula, again, hunched forward, elevating the elbows, and using all the muscles of the back and the spine. And all this accumulates in a kyphosis, a hunching over, and a forward tilt of the pelvis. And the forward tilt of the pelvis results in shortening of your hamstrings. Now, as I struggle with my kicks in karate, and I'm not as high as my son, far from it, I reflect on 30 years of surgery, perhaps standing in the wrong posture with a forward tilt, and that's perhaps why I've got very tight hamstrings, because I've been standing like a crane. So the other thing then is to understand the function of the upper limb. Well, the humerus is attached to the scapula, and the scapula is one of the only bones in the body, or is the only bone in the body, that has not got a fixed position at the top and bottom. It's not joined to two other bones. It's joined by a ligament to the clavicle at the acromioclavicular joint, but otherwise it slides and moves over the rib cage with the major muscles. And in doing so, presents the glenohumeral joint at different angles to allow you to move your upper limb. So the main movements are protraction, moving the scapula forward, retraction, rotation up, rotation in, elevation and depression, using the muscles of the trapezius, the rhomboids, the pectoralis muscles, the serratus anterior. But all those are really big muscles. And if you're standing at the table with your scapula fixed, elbows out, hunched forward, you're immediately using your trapezius, your rhomboids, your pectoralis muscles, and you've destabilized the triangles of muscles that are supporting your head and neck. So it is vitally important that you stand at the table correctly. And by way of example, and that's why I think the ironing board is a surgeon's best friend, is quite simply this. Think about it. When you go to iron, and I hope you do, you're not going to iron with the table down there and hunch over. No. Likewise, you're not going to iron up here with your elbows out and fixing your scapula and employing all the muscles. You decide automatically and reflexly, I put it to you, to iron at a height where your upper limb is most comfortable in the relaxed position. Like that. And like that means that for me and you, it's going to be different. For me and the assistant is going to be different. And as I said last week, with an assistant of different heights, you've both got to be in a relaxed position. The elbows do need to be by the side. The shoulders do need to be back. Your chin needs to be in, not protruding, and your head slightly declined to look at your hands. The elbows are extended and the hands are palmar flexed. And this position I liken to Thunderbird puppets, or puppet position. It's just simply relaxed. Now, the great thing about the upper limb, it's designed to get your hands into positions that are unique to Homo sapiens. No matter what position is, pronation and supination can happen no matter the angle of the humerus and the spine. That enables us to feed ourselves, to clean ourselves, and all the other necessary functions. But I put it to you, there's another important reason why we need to think about the upper limb and its function. Because really, for surgery, what I'm trying to teach is lightness of touch. What I'm trying to impress upon you is to hold your instruments such that the palp of the fingers are touching the instruments and you get that haptic feel back. Unless you have that feel of the instrument, you will not have a feel of the tissue. And what is interesting, the way the flexors of the forearm work, is the Popeye muscle, the flexor digitorum profundus, which is one of the biggest muscles in the third compartment, deep compartment of the forearm, runs through under the flexor retinaculum and inserts into the base of the distal phalanx. Literally there. And if you think of climbers holding onto walls, and I saw a YouTube of a climber walking around kitchen cupboards, hanging onto their fingers, they're using the flexor digitorum profundus. But that runs through the flexor digitorum superficialis as a pulley, and that one runs through the hand, splits into two, forming a sheath through which the flexor digitorum profundus extends, and that it sits into the base of the second phalanges. And both those muscles are used for gripping. But note, as I grip there, that my wrist is extended to maximize the force that I bring in flexing, bringing the proximal phalanx and middle phalanx into a fist. And as I explained before, the muscles in the intrinsic muscles of the hand are the ones that I would like to see used in surgery. And those are the lumbricals in interossi. And essentially, the lumbricals in interossi flex the carpal phalangeal joints and extend the interphalangeal joints like that. And if I hold this in that position and extend my hand, I cannot maintain the extension of my fingers. And in self-defense, to get somebody to release a weapon, you either extend or flex and you break the grip. And that is the grip that we do not want to see in surgery. So if you're standing properly with your hands palmar flexed, you have neutralized as far as possible the flexor digitorum profundus and flexor pollicis longus, which are two gripping, powerful muscles. We do not need those in surgery. We need to actually be able to use our upper limb to get our hands in a position to use them for what they're designed for. Lightness of touch and feel to bring the surfaces together. Now, you know that your upper limb is very good at pronation, supination. Okay, there you go, pronation, supination. And what's great about the forearm, it gets your hand into both planes to perform every function that you require. And that is unique to Homo sapiens. That is unique. So I can, with my scapula, humerus, move my lower arm and my hand into any position to do the job, to focus on hand movement. The rotation of the forearm with pronatus quadratus and pronatus teres, two small muscles of the forearm, rotate the radius and fold it over the ulna on a line between the index finger and the common flexor origin. And we know this is effective. If I take a screwdriver and put it in my hand and hold it out towards you, I can effectively pronate all the time there. Okay? But what's interesting, the clockwise movement, the supination, employs the most powerful muscle in your upper arm, which is the biceps. The biceps, clockwise movement for tightening screws. And that is why screwdrivers and screws are designed that way, to maximize the function of your upper limb. But But we don't want to be doing that and using biceps in our surgery. We want to be using the smaller muscles of the forearm and the intrinsic muscles of the hand. So in the same way I've held the screwdriver, I want you to think about holding a needle holder as I'm holding the screwdriver. And the needle holder is held as what I call the benediction sign. That the point of rotation is between my index finger and middle finger, and the pronation folds it over and folds it back. And I'm using the intrinsic muscles of my hand to lightly hold the instrument, and the small muscles of my forearm to pronate and supinate. So the very foundation of our surgery, the action, the lightness of touch, the movement, all starts with posture. In our published article of From Golfer to Airline Pilot, I described my power matrix, which is a diagonal operational matrix looking at fundamental movements and principles throughout, and you'll see that on the Black Belt Academy. But it all starts with posture and standing correctly. Not only is it good for your surgery and lightness of touch, but it is very good for your health. So next week we're going to continue our story, because everything we do is inside the body and at depth. And I really do think we're teaching surgeons basic skills the wrong way, because we have them sitting down at a table with a wrist and elbow at the same level. But as you see here, my wrist is lower than my elbow, and the implications for the angles of your needle and your mounting are significant. It is like learning to play golf sitting down. So I would implore all basic skills stations and teachers to start using an ironing board, because in theatre a table goes up and down, and before you start operating, please check the height and make a stand. Please adjust the table. The joke is that the operating table is remote controlled, because you call out and the anaesthetist changes that. But that is one of the common tete-a-tetes between the surgeon and an anaesthetist, or what is described as a blood-brain barrier. So I hope I've given you food for thought. Go to the web page. I've written an article on posture and given you some references. There are even some videos online offering some exercises you can do to actually relieve the stress in your shoulders, like leaning against the door, at the top or at the side to extend, and simple exercises keeping it chin tucked in, shoulders against the wall, and walk forward. But mind you, a little caution. If you've got tingling or discomfort down the hand, do see somebody about it. That is exactly what I had in my hands when I went to see Jake about a 95% stenosis at C6, C5 root canal. Years of wear and tear. And I certainly feel it now in karate when I'm trying to actually improve my flexibility and correct the forward tilt of my pelvis, which I think has a long-term impact on my hamstrings that are very tight. Surgery is, in many respects, not unlike sport. And if you are seeing a sports coach, they would attend to your posture, attend to your fitness, attend to your well-being and nutrition and sleep and status, because all those are important for you to function properly as a safe and effective surgeon. Thank you very much indeed for joining the Black Belt Academy of Surgical Skills. I look forward to seeing you next week as we start our journey again and explore what has happened inside the box and how to orientate your needles and get that perfect rotation. Remember, if you failed yesterday, stand up today and make a stand and stand up for your patients. Thank you. Good night, good day, good evening. Please spread the word, and I look forward to seeing you next week. Bye-bye.